Hi, I'm Dr. Joe Suker with the Arizona Trauma Association, and this is Trauma in a Flash. Extenuating hemorrhage is a leading cause of mortality in trauma patients. The technique for placing a low-profile resuscitative endovascular balloon catheter occlusion system via the common femoral artery is shown in the following steps. Shown here are some basic tools required to place a low-profile REBOA catheter: an introducer needle, a guide wire, an 11-blade scalpel, a 7 French introducer catheter and dilator, and a REBOA catheter with locking grip and suture. First, perform a chest x-ray to ensure that there is no evidence of aortic injury. Next, using ultrasound, identify and percutaneously cannulate the common femoral artery. Consider placing a 5 French femoral artery catheter in any patient who you anticipate might require REBOA. This can quickly be upsized to a 7 French introducer sheath. Ensure the balloon is completely deflated by pulling back on the syringe and locking the port closed while maintaining negative pressure. Measure the length from the access hub to zone 1 and zone 3. Zone 1 is distal to the left subclavian artery and proximal to the celiac vessels. Measure and record the distance from the access hub to the sternal notch. Zone 3 is distal to the renal arteries and proximal to the aortic bifurcation. Measure and record the distance from the access hub to the xiphoid process. Insert the catheter to zone 1. Zone 3 placement is reserved for patients with hemorrhage that is known to be distal to the aortic bifurcation. An X-ray should be performed to confirm the position of the catheter before balloon inflation. The balloon should not be inflated in zone 2. This is the area from the diaphragm to the renal arteries. While monitoring the arterial waveform from the catheter's tip, slowly inflate the balloon, stopping the inflation when you see an increase in the waveform. The manufacturer lists typical inflation volumes of approximately 8 cc's for zone 1 and 5 cc's for zone 3. The maximum inflation is 24 cc's, or a 32 millimeter balloon diameter. Of note, many surgeons have described that their teams were lulled into complacency at this time due to the improvement of blood pressure on the monitor. Therefore, ensure your team maintains their vigilance in expeditiously moving to the operating room. Finally, the general rule is that any patient in shock with extenuating hemorrhage originating below the level of the diaphragm should be considered for this procedure. Thank you for watching this week's episode of Trauma in a Flash.